Good morning. We're going to pick up on diseases, starting with the heart. I sent out the links yesterday to hopefully you got, and if you're just jumping in, make sure you type chat or type here in the chat. Okay. Okay, so we will, let me get this started. Sorry, guys. But I did copy those videos. And I think if I sent them, because I think, and I know like Joycelyn, you responded when I got the first video out to you, but then I think someone tried it and that one didn't work. So the ones I sent yesterday should work. And then I'll try to get this one out today. So if anybody has to bop out, and you need to replay it. And the first thing I want to say when I talk about these diseases, it's very important to understand how a normal heart functions so that we understand when it's failing, where is the problem? If, like I said, if you think about the heart and all of the vessels as one connected system, it's like a pump and a series of pipes. And I've used the analogy before that think about like the water system. You've got the water plant and it's a series of pipes. And then, when it leaves the plant, it's very large pipes and then it's going to divide to all the houses. We're kind of like the arterioles, capillaries. It's kind of like once it gets to houses. But, if you had like a water main break where one major pipe let out all the water, that's going to drop the pressure in the system. The pump's going to have to pump harder unless you like fix that leak. And also, if every house at once just turned their water up full blast, it's going to have to pump more water. If we all turned our water off, that pressure would increase. The water pump isn't going to have to pump as hard because none of us are using water. And so if you think about the cardiac system, it's a feedback. Okay, when the heart is beating, the size of the vessels it's beating into is going to have an effect. Also, the ability for the pump to be able to pump efficiently. So when I talked about those arteries being muscular and they can change their diameter, if all the arteries are dilated, think about it. The heart is going to probably have to pump harder the heart wants to keep the vessels full. It wants to fill the pipes. So anytime we have issues that cause vasodilation, and of course, we're going into anesthesia next. So understanding this is huge, is that a lot of anesthetics cause vasodilation. And anytime that happens, the heart's natural reaction is going to be to either try to pump faster or harder. So when we see an animal under anesthesia that has a very high heart rate, everyone thinks pain. That makes sense. But my brain also says, does my animal have low blood pressure? Because the natural reaction to low blood pressure is to increase the heart rate. So I'm going to talk about these diseases, but I want to also get into I want you to start to think about this relationship between the vessels and the heart and what's happening. One of the most common diseases that, I won't say it's a very super common, is canine dilated cardiomyopathy. So when I said day one, a lot of people put cardiomyopathy as a disease, but there are different forms. So the dilated is the heart is too big. And this is a weakness. Now, there's two blanks there. Whoopsie. Sorry. Okay. Two blanks here, but it's acquired cardiovascular disease It's dilation of the chambers of the heart. Let me just type it in the little chat screen in case people can't hear me. And decreased cardiac output. So the problem is, if you think about the heart, cardiac output is how much blood is being ejected from the heart from the left side of the heart during systole. Because when the heart squeezes, you know, the right side is going to the lungs, the left side is going to the body. Now, not that we don't care about the lungs, but when we measure cardiac output, is the heart's ability to pump blood to the body. If you have a dilated heart, it's like a big weak sac. When it squeezes, it's not like nice and strong. It's kind of like, so if you think about it, it's not pumping out as much. The problem that we get is we have impaired systolic function. During systole, we're not putting out enough. And if you remember, we talked about cardiac output is heart rate times stroke volume. I'm going to type that too. So the stroke volume is the amount of blood being ejected. They have to measure that with an echocardiogram. Okay, you can't determine cardiac output without an ultrasound of the heart. But we can get a heart rate. But if so, that's all interrelated. So when we test for this, we test for cardiac output, we measure the heart rate, and then we try to determine why is the heart not putting out enough. And again, when you view this PowerPoint, you should be able to view it in the notes pages, and you can see extra notes. Breeds that we see this on, I'm going to say the #1 dog we see it in is Dobermans. Dobermans genetically are prone to dilated cardiomyopathy. Boxers are on the list. Newfoundlands, so when I talk about giant breeds, Newfoundlands and Irish Wolfhounds, that'd be probably like my top. And most of the time, those are the dogs that would come into our study, our heart study at Purdue. Also, for a mid-sized dog, potentially cockers, but not going to be as common. And males are more affected than females. Not that a female can't get it, but it's usually, and then usually ages are about 4 to 10 on average. So 4 to 10 years old is about the average. But this is definitely more of a large breed disease. We don't see it as much in the small breeds. When we get into mitral valve and murmurs, tends to affect the smaller breeds a little bit more. The issue, oh, Ashlyn, I'm so sorry. I know I love Dobermans. I mean, I have Boxer now, and he's awesome, but I've always wanted a Doberman. I'm like, mine will definitely have cardiomyopathy because that's just me. So hopefully a Doberman owner, usually if they're going to be responsible, they'll be educated to look for it. We're going to talk about the clinical signs. I know they look menacing, but Dobermans are very, very sweet. They were kind of the Rottweilers of the 70s. So now Rottweilers are like this dangerous breed that people, and then back then it was Dobermans. So there are some potential reason, yeah, and Michaela Warwick, I should have put Great Danes on here, but they are a giant breed. So they kind of fit into that category. Let me try to show you. Can you guys see these X-ray images? Okay. Now, when you get used to looking at more and more X-rays, you'll see like what a normal heart. I would say close to normal. They barely have another. Okay. This one down here. Now, remember I said the heart is supposed to be kind of like on an angle pointing caudal. do you see this heart is a little more straight up and down, which sometimes is indicative of it being enlarged. And when it increases in size, sometimes it shifts the axis. But if you look at some of these up here, I mean, that on a VD X-ray, and look at this one. I mean, the heart should not, we call it a basketball heart. It's round. The heart should never be round like a basketball. Oh, good. Ray, good to know that you guys can see the extra notes. And if you can't, when you open the notes later, hopefully you can. But yeah, there's extra notes in the notes page that you should have access to. So thanks for letting me know that. Look how big that is. So when we take an X-ray, now there can be pericardial effusion can sometimes make a heart look that round. So when you see it round like this, it doesn't always mean dilated cardiomyopathy, but you know, it's going to point us in that direction. We have to rule it out. So again, there's other things that cause these X-rays. I think there was like, look at this one. I mean, that is pretty huge. Now, something that I want to bring up, it is not in the notes because this is a little bit older. Well, it's bringing up these taurine, carotene deficiencies. Most of the time in these guys, it's genetic. Whether they had a nutritional protozoa, and can be idiopathic, it just affected them. But one thing that you guys are coming into is there is this craze of this grain-free diet. And I don't know if you guys talked about it in nutrition at all, but what we're seeing is because of the high level of like lentils and legumes, which would be like, you know, your beans and peas and things like that, to compensate for not in the grain, they'll sometimes add more of those legumes and things of that nature. And they think that what that's doing is that's contributing to breeds getting dilated cardiomyopathy that would not normally get it. So there's a lot of posts on Facebook, but there was one post of these two golden retrievers that, you know, 4 and 6 years old, and they came in with very enlarged hearts, had been fed almost exclusively a grain-free diet for quite a while. When they stopped the diet, went back to a traditional diet, the myopathy started to resolve. What is key is that if it's a Doberman eating grain-free, it's a little bit more challenging. If it was genetic, his heart's not going to go back to normal, okay? Dogs that get dilated cardiomyopathy, you have to use medications to manage it. It's not a fixable condition. If it's diet-induced cardiomyopathy, it can be usually reversed by going back to a normal diet. So what I would say is, and that's where people aren't understanding, and there's lots of arguments about this, is if it's diet related, you can fix it. If it was genetic, it's not going to be fixed. So I am not a big proponent of grain-free. There are allergy dogs that may help. Everybody thinks that grain-free is the greatest thing. Unless they're having a massive allergy problem, and you probably should diagnose that without just feeding grain-free, that's a different story. Okay, but most dogs should be able to handle grains without a problem. So I will say, again, when I was in your guys' shoes and starting out and in my clinics, I mean, there was some allergy foods. But you go to the pet store now, and I'm overwhelmed at how many different brands there are. So, you know, you guys in the clinic will get lots of questions from people adopting puppies, and what should I feed my dog, and what do you feed your dog, and what do you think? And I've told you there's a reason I'm not teaching you nutrition. It's not my strong suit, and I'm not really into nutrition. But I even get overwhelmed when I had to go get food for Bo, because I was like, oh my gosh, what on earth do we get him? So you have to have some decent understanding of nutrition to be able to talk to these clients and try to get them out of this fad mentality and talk about true science, true nutrition. I personally had to, you know, it was a big joke between me and my husband because when we got the boxer, he wanted to feed it Blue Buffalo because he went on mysweetpuppy.net and it said that that's the best for boxers because of the high protein. And I was like, why don't we go to the nutrition websites and the veterinary websites, not mysweetpuppy.net? And this is my own husband, and I was floored. So we have him on From now. He's doing great. It's balanced, has protein, grains, chicken. He's doing fine. So anyhow, I just want to throw that out there. So some of the clinical signs, and the big thing is what potentially the owner's going to see. What are you going to notice when they come in? Now there's right-sided and left-sided heart failure. They can be in one or the other, or they can be in both if they're in late stages. You're going to start to see ascites, which is an increase in abdominal fluid. So they'll come in sometimes looking a little pot-bellied. So ascites affects the abdomen. Hepatomegaly, enlarged liver. Sometimes there's weight loss and abdominal distension. So abdominal distension is an early sign of ascites, okay? And so the owner might notice that. And what happens is they get more pot belly, but they look skinny everywhere else. And then they kind of got this big belly. If it's affecting more of the left side, then we could get coughing, pulmonary edema, and syncope is even fainting. Okay, so syncope, and that's because the heart doesn't have the ability to pump the blood to the brain. And then what happens? You get a lack of oxygen, and they literally pass out. And then all of a sudden come to. So any of these signs, and one thing to add on here, and we're going to talk about it on the next slide, is also the big thing is exercise intolerance. This disease builds. Now there's dogs that are very good at hiding symptoms. And then sometimes owners are like, one day he's catching the ball, the next day he's 100% abnormal. That's very odd in this disease, but it depends on what the people do with their dogs. You know, if you're a person that jogs, 5 miles every day, you're probably going to pick up on this versus the couch potato dog. You know, the dog that just lays around. So depending on how active the dog has been normally, you know, someone's going to pick up on, and that's probably the number one thing when we see heart disease that owners complain about is exercise. So definitely I've stressed that exercise intolerance is a major symptom of cardiac disease. Now, one thing that I want to mention is auscultation. And when you're listening to these dogs, and hopefully you can get a good sound like they're not being a spaz, is the breath sounds and heart sounds with pleural effusion. Or versus pulmonary edema. So one of the questions I ask on the homework, I'm very into what is the difference between pleural effusion, pulmonary edema. In pleural effusion, everything is going to be muffled. Everything is muffled because if you think about it, you have a chest cavity that has fluid around the lungs. So when you're trying to listen, and then that fluid is muffling your ability to hear the sounds through that fluid. Now in pulmonary edema, which is the fluid inside the lung tissue, when they inhale and exhale, you hear more crackling. So they're called crackles. I really encourage, anytime we know we have a dog with pleural effusion, pulmonary edema, to try to listen to that animal. The other thing is, if you think about the chest cavity, this is hard to do at home. If this is the chest, you've got dorsal cavity, you've got ventral cavity. So fluid is going to go where? Ventral. So if I'm listening to lung sounds, I think of them like quadrants. If you divide the chest cavity in 4 pieces, you've got cranial dorsal, caudal dorsal, cranial ventral, caudal ventral. Okay. Now, if I listen in 4 spots, if I'm talking about pleural effusion, fluid is going to go to the bottom and rise. So sometimes um, you hear muffled low and you hear better sounds high. Pulmonary edema is fluid in all the lungs, so you might hear crackles all over, but fluid in generally settles. So sometimes, that's why if you can, I always say try to listen to the chest in 4 spots. I remember we got those dogs from the shelter, and there was a pity. We had a bunch of them had kennel cough bad, and a couple maybe had pneumonia. I was trying to tell as many people, I'm like, not that I want to stress the dog, but I'm like, you really should go listen to this dog's chest, because we don't have a lot of respiratory cases. And that's probably something that took me the longest to get fairly decent at, was lung sounds. So it is challenging because you've got panting and you've got snorting. One thing that I always try to, if you put your stethoscope on their chest like of a pug, and you hear all that, this can be great for video. You make all those sounds, and then you're listening and you're like, oh my God, this chest sounds terrible. And I'm like, take your stethoscope and put it up by their neck. Now, people look at you weird when you put the stethoscope on their neck, but if it's upper airway, it's going to be louder up here than it is here. If it is truly that bad in the chest and you put the stethoscope up here, you're not going to hear anything. So it's one way to tell. Now, obviously, if you're listening to a pug and they're doing all this when they come in, you're probably going to assume the weird sounds are called referred upper airway. But that's what you can do. I had an extern once tell me, she goes, well, you're not going to hear the heart very good if you put the stethoscope on their neck. And I was like, I know where to listen to the heart. I'm listening for upper airway sounds. So I taught her, I was like, this is what you're doing. You're trying to determine, are the sounds coming from here or from down here? The other thing is, and again, the doctor is always listening to this. So there's never been a situation where they're making the call based on my opinion. But I will do my first exam, and then I go back to the doctor and I'm like, the chest sounds weird. I hear something crackly. Oh, it's just muffled. And then the doctor will go, okay. And then they listen. So you're always going to be backed up, but it's, you're kind of the first line of like, is this a problem? Do we need to investigate this further? And then your slow CRT, your refill time, because the heart is not pumping efficiently, it's not pumping blood out to the very end count. If you're looking here, the heart has to pump blood all the way from the heart to the tiny little gums that you're pushing on. And again, if that's not pumping, you might have a slow refill time because of inadequate perfusion. That is the consequence of all of this, is if the heart cannot get blood to the tissues, to the brain, to the gums, have adequate blood pressure, you do not have adequate perfusion. And perfusion is adequate oxygenated blood flow to every cell tissue that needs it. So perfusion, perfusion, perfusion. Get ready for anesthesia because I will pound this into your brain. Perfusion is what we're trying to maintain, and that's what we have to do. So testing for this, echocardiography is basically an ultrasound of the heart. And this is the best way to diagnose it. So this would be, and what we're looking for, and this is why there's like a blank underneath there, is you're looking for dilated chambers. Hopefully you guys have access to the notes, so this is kind of in the notes page, but you're looking for dilated chambers. All echocardiograms do something called Doppler, cardiac ultrasounds. When we do a Doppler for blood pressure, we put the little crystal near a peripheral artery and we check blood pressure. Doppler ultrasound is measuring the pressure inside the heart. So that Doppler is built into the ultrasound probe. So you can do a Doppler ultrasound, and it's going to measure the chamber size. and it's going to tell you how much pressure. And I will tell you, an average echocardiogram is going to run about $350 to $400. Now, normally a echocardiogram is done with either a board certified radiologist or a board certified cardiologist. If your vet has access to it, a lot of vet clinics will get like a small little ultrasound machine because they can check for fluid, they can check for, you know, all kinds of conditions. But if you're going to do an ultrasound of the heart to diagnose heart disease, it really needs to be done by one of those two people, because there's special ultrasounds that can measure, ours at VCA could measure Doppler and all the different things. I think we've got one at school. The one we have at school is a little bit limited, doesn't have that Doppler. They can even do an ECG inside the probe. They can put it on the heart and it'll give you an ECG tracing. So it's pretty cool. Now, radiographs is what I just showed you. So radiographs are going to give you, they're going to show you what's called cardiomegaly. And that's just an enlarged heart. But remember what I said, an enlarged heart does not necessarily mean it's cardiomyopathy. Now, if it's a Doberman and he's 7 years old and we have a basketball-sized heart, we're all thinking, ding, 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 it's this. But again, there's other diseases that it could possibly be. So an X-ray is just going to probably confirm that we need to do an echocardiogram. And usually when patients do what's called a cardiac consult, it was an ECG, 3 views of the chest, and an echocardiogram. And I want to say that whole thing was $500 to $600 to accomplish all 3. Now, an ECG, oh, the other thing that I should mention, a radiograph is going to tell you a few things. Obviously, it's looking for enlarged heart. It's also going to pick up effusions, like if there's pleural effusion or pulmonary edema. You can see that on an X-ray. So it can confirm pulmonary edema, pleural effusion, heart size. You can also sometimes sneak a little abdomen in the chest X-ray. When you guys do RAD2, you know, they teach you to collimate and only shoot the chest, but sometimes you get a little bit of the abdomen. And remember, the liver is up under the diaphragm. So sometimes you can see that hepatomegaly, or you can see fluid in that little bit of the abdomen that gets stuck in the X-ray. But these are all things that we look for. Now, the ECG, there's a variety of arrhythmias that go with cardiomyopathy. Now remember, ECG is picking up electrical activity. If you have a diseased heart muscle, that electrical activity has to be conducted through the heart muscle, right? All of those fibers that we talk about are embedded in the muscle of the heart. So it only makes sense that if we have abnormal muscle, we could potentially have abnormal activity. So sometimes you're going to pick up on a variety of, you guys had Tech 4 already with ECGs. So you talked about arrhythmias. Okay. So you've talked about some that were, you can sometimes get atrial fibrillation. Sometimes we get the ventricular arrhythmias, or you get these wide complexes. We talk a little bit about that in anesthesia, but one thing is, I know everybody's intimidated by ECGs, and when you're watching an ECG on a patient, it takes practice. One thing that's when I've had patients in trouble, and when I've had patients under anesthesia where things aren't going well, sometimes it's a knee-jerk gut reaction, but the ECG starts to get wide and bizarre. We just call it wide and bizarre. And when I start seeing that, I'm like, no, 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 no. And I mean, I had a patient, all of a sudden I could see the heart rate was going beep, 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 and the ECG was getting real wide, and I turned that patient off immediately. We were getting ready to do radiation for a brain tumor, and I turned him off, and we woke him up, and we did a cardiac workup, because we were like, we're about to anesthetize this dog 16 times. Brain radiation is 16 treatments. And everything, he ended up having a little bit of an enlarged heart. Now, increased intracranial pressure drops the heart rate. So normally when I have a brain patient and the heart rate drops, I think we're having like a potential swelling in the brain. So, you know, there's just sometimes these gut reactions that you'll develop, and that wide and bizarre ECG, you know, in anesthesia is abnormal, but it can also be a symptom of this disease. So those are things that we do to diagnose it. But the big thing is there is no cure. All we are going to try to do is make this patient comfortable. Unfortunately, this is a disease that's going to progress. How quickly it progresses, we do not know. So this is where good client education is going to be key. One thing I forgot to mention on the previous slide is we can do something in animals called a Holter monitor. This is where we put, it almost looks like a vest, and it has little ECG probes, and the patient wears it for 24 hours, and it has a little monitor inside, and it monitors that dog's ECG for 24 hours. The owner comes back, and we have the cartridge, and we ship it back to the company, and they will print out basically this well, they're not going to print out all those strips, but they're going to give us a 24-hour report of the heart activity. So if you have a dog that has syncope, coughing, a lot of ECG or a lot of cardiologists will say, let's do a Holter study. And that literally means we put this vest on the dog. The owner is supposed to like write at times, like he was eating. At 5 o'clock, he was playing with his ball. At 9 o'clock, he went to bed, because everything's event related. So if we see an increase in heart rate, oh, he was playing ball at 5 o'clock. Okay, that's why his heart rate. If he's sleeping and his heart rate went up, we're like, he should be sleeping, it should be low. So the owner is required to keep kind of a log of what was happening in that 24-hour, and that gets shipped as well with the little monitor, and then we develop this report. So I neglected to talk about what a Holter monitor is. But that's usually done, there's a separate company. Most regular vets can order a Holter monitor too, like they can get it from this company, and it's fairly easy to do. So keeping them comfortable, treatment is based on the symptoms. So diuretics, which furosemide or Lasix is the number one, that's what we use. Basically, furosemide, the problem in cardiomyopathy, the heart is not pumping properly. And remember, part of the cardiovascular system is to balance water in the body. So there needs to be enough water in the blood vessels, or, you know, part of the plasma is body water. And then there's water in the tissues. So if you remember osmosis and like diffusion, and, you know, we've got fluid in the vessels, we've got fluid in the tissues, and it kind of stays in even keel. But when we have abnormal circulation and abnormal function of the heart, that fluid tends to build up in other areas: abdomen, pleural space, lungs. So the places that we see fluid in heart disease, it's either going to be in the abdomen, the pleural cavity, and most often in this disease, it's the abdomen or the lungs. Those are the two. You get that pot belly, or you get these dogs coughing. And the coughing, well, I'm going to tell you, coughing comes from two reasons. It's either fluid in the lungs, but if you remember that super big heart, that heart might be pushing up on the trachea, okay? Because the trachea is coming into the chest, the heart is enlarging. So sometimes it's a dual component. There's fluid, but there's also some tracheal compression if the heart gets too big. Now, most often it's fluid, but sometimes you'll see a deviated trachea on x-ray because of this abnormal position. Furosemide, Lasix is going to force that fluid to the kidneys. When they're on Lasix, and I'm going to ask you, so people that are in here, what do I have to tell the owner when the dog's on Lasix? They're going to drink a lot, and they're going to pee a lot. Mostly they're going to pee a lot. And their pee is going to look like water. Or you should say their urine. But so sometimes the owner's like, oh my God, it's like their urine was water. And sometimes they're like, did he spill his water or did he pee? Now, it should have a faint yellow color. Sometimes I've wiped it up. Actually, my cat has been in the bathroom because she's not acting well again. And so I don't know. There was a little bit of water on the floor, and I don't know if she peed, but I wiped it up with a white paper towel, and it had a little yellow tinge. And I'm like, okay, it's urine. It's not spilled water or something. So be aware of telling them increased urination, increased drinking. There's a drug called digoxin that's going to increase cardiac contractility, which is how hard it contracts. If I increase how hard it contracts, I should increase output. Stronger the pump, stronger the output. When we talk about all these receptors, and we've always talked about what it does, ACE inhibitors, there's a drug called enalapril. What enalapril does, normally the ACE inhibitors are going to cause vasoconstriction. Enalapril is going to help relieve some of that pressure. Remember, the heart is pumping out to a pipe. If this pipe is very narrow, it might be harder for that heart to pump. If I release that pipe, it's going to be easier for the heart to pump. It's kind of like the analogy when I've talked to you guys about, I'm going to put a balloon on a straw, and if I'm going to give you one of those big Slurpee straws, blow up the balloon. Now I'm going to give you one of those little cocktail stirrers, and I want you to still blow up the balloon. Well, you're blowing through what a big cocktail straw versus, a little cocktail straw versus a big straw. So you think about the heart pumping into a vessel, that's the relationship. We can give drugs that can adjust the pressure so the heart doesn't have to work as hard. That's what we're trying to do. And then we've got atenolol and propranolol. Atenolol and propranolol, beta blockers, usually help with the arrhythmias. So atenolol and propranolol are drugs we'll use sometimes. What they will also do is they will decrease workload. My cat has a heart murmur. His is more, the other one we're going to talk about. But atenolol slows down his heart rate. So sometimes that'll help with arrhythmias, but it will also help the heart work. If the heart's pumping so fast, if we slow it down, sometimes it's more efficient. Large breed dogs have low heart rates. The bigger the dog, the lower the heart rate. I mean, a horse at rest probably has a heart rate between 30 and 50 beats a minute. It's a giant heart. It's like boom. Because anytime the heart beats, in diastole is when it fills up. So a big heart needs to spend a decent amount of time in relaxation to pump again. If I'm a Great Dane, I'm like a mini horse. I don't want a Great Dane to have heart rates in the hundreds and 150s. A Great Dane should be down in the 60 to 80s. Boom, fill, boom, fill. So sometimes in cardiomyopathy, they come in with high heart rates. Atenolol will slow that down. The other thing that we have to watch when you're working with these diuretics and we're working with ACE inhibitors is you have to be careful for azotemia, watch kidney function. Azotemia is an increase in BUN. Azo is pertaining to kidney, emia blood. So when you have azotemia, it means that your BUN is elevated because you're affecting perfusion and you're affecting that water balance. So you have to make sure. So normally kidney values are going to be monitored as well. It's obviously a poor prognosis. If they present, what they mean is symptomatic. By the time the owner notices coughing, exercise intolerance, fluid, we're typically, survival time, there's one quote of that 27 to 140 days, 6 months to 2 years. And again, this is just depending on when we catch it. Again, if you might be doing an x-ray of a dog for, like, say, a surgery or say a dental, and then all of a sudden you go, wow, the heart's big. That dog maybe wasn't coughing or anything. You just picked it up incidentally. So if you catch it early, you're probably going to be closer to that 1 to 2 years versus late stages closer to the 6 months. All have a different, and again, it is okay to treat this with medication. It's definitely worth a try. This is the other side of it. Hypertrophic cardiomyopathy. So this is another disease, but it causes the opposite problem. It's not as common, but the left ventricle muscles hypertrophy, fast growth. Troph is growth, hyper increased. So that thickened, that heart muscle is becoming very, very thick. Basically, it decreases filling. It can block outflow during systole when the heart's contracting, because those muscles are so thick. When the heart when it squeezes, there's more stuff in the way, so to speak. The left atrium can actually start to dilate because there's so much pressure. And the mitral valve, it says question valve, that should be mitral. So sometimes the consequence, you might think it's a mitral valve insufficiency, and it's actually a hypertrophic cardiomyopathy that caused mitral. You know, it's like the chicken and egg, which came first. So if you look at this picture, here's what a muscle should look like. And this is affecting mostly the muscles of the ventricle. Here is a super thick heart. See how thick that muscle is? Now look at my chamber, okay? If I want to, here's my coffee cup. I can hold a lot of coffee in that cup. If you give me one of those tiny little cups, I'm not gonna have as much coffee. If I'm a ventricle, normal size, and then you make it really narrow, when I pump out my next beat, am I gonna pump out as much blood? So what does that do to my cardiac output? It decreases it. So this is another thing. What is the consequence of the problem? The consequence is my chamber cannot hold as much blood. Therefore, when I push out of my chamber, I can't push out as much. And look at this atrium, it's like a balloon. The problem is that muscle is so strong that it's putting high pressure, and then the atrium becomes too big. I will tell you really quick, because I know we're almost getting done, but this is what I think my cat has. So I got one dying of hyperthyroid disease, and I've got the other one who has a murmur. The consequence, I'm jumping ahead a little bit, but this left atrium, when it's enlarged, so he has a murmur, okay? So basically he's getting an abnormal swirling. It's affecting his mitral valve, but that they can form clots in that atrium. And then those little clots swirl around. If one of those clots comes out of the heart and gets stuck in his lungs, or we have these cats that come in with thromboembolism that go to their back, they come in screaming. I hate when these cats come in, because I feel so bad for them. I almost want to immediately euthanize them, because it's basically like a clot travels to their back leg. Their back leg will be out like a stick. They can't move it. It's cold. You can't feel a pulse in that limb. And when you try to usually hold these cats, they're very dangerous because they're extremely painful. We had a girl get shredded up. She tried to get him out of the carrier, and he was screaming and flailing and claws. And I was like, let him go, let him go. Like, she just basically had to but the cat, it's not the fault of the cat. He was just so painful. So there's some consequences we're going to talk about. Now, what we deal with here, and a lot of this is on the notes underneath, sometimes they're asymptomatic. I just one day wanted to listen to my cat's heart. And then I went, he's got a murmur. He wasn't coughing. I mean, how do I know a cat's lethargic? Really? Cats don't typically cough. Cats don't do a lot. So a lot of times, this is more of a cat. If I haven't said that, this is seen more often in cats. But they can have fatigue. They can have cough. Sometimes they have tachypnea. What is tachypnea? Anybody want to type it in? PNEA is breathe. Someone might be typing, not trying to cut anyone off. Thank you. Yep. Great. Thanks, guys. Fast breathing. So tachypnea is they get this fast respiratory rate. They could also have dyspnea, which is difficulty breathing. So fast breathing, difficulty, increased respiratory effort, syncope, that's just like animals walking and then they fall over. They're passing out. You may or may not hear a murmur. It depends on how advanced it is, but that's what I heard. And then potentially sudden death during anesthesia. There are reports that, and I think it's important to understand, there are reports of male cats just dropping dead during a neuter. Cat comes in, neuter, seems healthy. The problem is that's a young cat, probably still active. Sometimes they do not have the murmur. And then you go to anesthetize them, and an anesthesia affects the dynamic of blood pressure, heart rate, blood flow to the brain. And then all of a sudden, the cat dies. A lot of times, again, they said it's more representative in male. And a lot of times it's a silent issue in male cats. Are we doing an ECG on every male cat that comes in for a neuter? And I'm going to tell you, ECGs on cats are not fun at all. Trying to get a cat to lay in lateral recumbency while you extend his limbs and clip clips to his skin. But anyway, and then what they found though is a lot of times those ECGs are normal in these guys. So unfortunately, now I don't want everybody now freaking out. They got a cat neuter. But listening to the heart, monitoring pulses, monitoring blood pressure is going to help. So blood work doesn't always pick up a lot of cardiac diseases, and radiographs are going to be potentially normal because this does not necessarily make the heart go like this. It's increasing inward. And when you take an x-ray of the heart, you're looking at the outside. You're not going to pick up on chamber size. So sometimes you're going to pick up that the left atrium can be bigger because of that pressure, but that's a very, that's going to be in a little bit later stages. Left atrial enlargement doesn't. But what you're going to see is your echocardiogram will be your gold standard. Your echocardiogram measures the thickness of the myocardium, and it's going to measure chamber size. So they can put the little arrow, they have this little arrow, and it measures all the chamber. So if it's increased, and then they're going to measure flow, they're going to pick up on this. So the only way to really truly diagnose this is with an ultrasound. One thing that, restricting exercise, warning owners of sudden death, which that's a conversation the veterinarian needs to really have, because you don't want to be like, hey, your cat might just drop over dead. It's like, what are we going to see? What are we going to start to notice? There are some, I want to say it's called HD. There's a Hill's prescription diet, and HD is for heart disease. I love that the Hill's foods are like the letter with the D. I'm a simple person. Hill's have been around forever. There's probably a lot of other cardiac diets, but mostly they're working on limiting sodium. Sodium increases water. Water increase in the vessels increases workload and blood pressure. So what we're trying to do, most people with heart disease limit their sodium intake because of it's affecting that water balance. You have to really treat the symptoms. They can get pulmonary edema with this because it affects that relationship of pressure of flow to the lungs. Lot of different drugs here. One thing that I want to mention is it talks here about beta blockers, calcium channels, improve myocardial oxygenation. This is one of my soapbox items that I talk about definite other situations. When that heart is pumping, that muscle needs to get perfused oxygen, okay? The problem with hypertrophic cardiomyopathy and sometimes sudden death is the muscle is so thick and working hard that remember I talked about the coronary arteries are on the outside of the heart, and that's how the muscle of the heart gets its blood. If I'm making a heart work very fast and I'm making that heart work hard, the problem is that muscle's so thick that blood, that oxygenated blood, cannot penetrate the myocardium. And then what happens is you have heart muscle that's not getting oxygen. That's where the sudden death and the fatal arrhythmias happen, is because the muscle is not getting oxygen. And when heart muscle dies and you have these arrhythmias, it can be fatal. So one of the things we treat is, first of all, I talked about negative inotropy effects, calcium channel blockers. All what they're trying to do is slow down the heart rate. So in my cat, we try to get his heart rate to slow down. If his heart pumps slower, it spends more time in diastole and it tries to help perfusion. You're also trying to help relax those coronary arteries and help perfuse the heart. So that's all that that's saying there for treatment. Get the heart slower, increase blood flow to the myocardium, and hopefully increase myocardial oxygenation or oxygen consumption. Reducing the heart rate helps ventricular filling. So I hope everybody's getting that. The slower my heart beats, the more time my heart spends in diastole. That's when the ventricles fill. If you have a heart beating super fast, it spends less time in diastole, therefore the next heartbeat is not pumping out as much blood. Hopefully that makes sense. That's just basic physics, basic what's happening. So again, we can take drugs to try and affect all of this so the heart doesn't work so hard, increase oxygen to the heart muscle, increase the amount of blood that pumps out. And there's too much more I want to talk about here. So let me stop here. These two are fairly common, so I want to talk about that. Do you have any questions?